So a very, very warm welcome everyone to today's Health Law and Ethics Network seminar. My name is Megan Prichter. I'm a senior lecturer at Melbourne's Law School, and I'm not the usual face of the person that hosts these wonderful seminars, but two of our directors, Paula O'Brien and Michelle Taylor-Sands, are unfortunately unavailable today, and our third director, Chris, is speaking. So they very kindly asked me to chair today's session. I will start by acknowledging that I'm joining today from the beautiful unceded lands of the Wurundjeri people of the Kulin Nations, and pay my respects to their elders, past and present. And I extend that respect to any Indigenous people joining us today on this call. And you might want to put in the chat whose country you are joining this call from. Today we have a wonderful presentation on the ethics of genomic newborn screening, empirical and conceptual perspectives, and we have two expert speakers. So I'll introduce them now. So today we have Danya Vears. Danya is a Principal Research Fellow and Team Leader in Biomedical Ethics at the Murdoch Children's Research Institute and an Associate Professor at the University of Melbourne in the Department of Paediatrics. Danya is a social scientist with a background in genetic counselling, which makes her supremely well qualified to give today's presentation. Her research uses empirical methods and theory to explore ethical issues relating to genomics. And I also warmly welcome our second speaker, Christopher Gyngell. He is a team leader in biomedical ethics at the Murdoch Children's Research Institute and a senior lecturer at the University of Melbourne, also in the Department of Paediatrics. Chris has a PhD in philosophy and a background in genetics and corporate ethics. His research explores the ethical implications of novel technologies, including genomics, AI, gene editing, and stem cell therapies. And he, as I said, is a director of the Health Law and Ethics Network. So over to you. I believe that, Danya, you're first off, cab off the rank today.
I am. Thank you very much for having us. So yeah, Chris and I co-lead the biomedical ethics research group together, and we often do work coming from at things from quite different perspectives. So I'm often from an empirical perspective, and he's often from a more conceptual perspective. So it's really nice to be able to join the two today and give this presentation together. So although this is the overall title of our presentation, my presentation is really about public perspectives on genomic newborn screening, and I've taken a qualitative approach to do that. So just to orientate you a little bit about newborn screening in Australia, it is a government-funded public health initiative, and in Australia we generally screen for about 25 conditions, although that changes depending on which state or territory you're in. It is performed by using a heel prick test. So we take heel prick, the blood from the heel prick of the baby, and that consent is also taken at that point in time, and that is done by the nurse or a midwife, and it can happen at hospital or at home depending on the context. At that point, laboratories will use biochemical testing in order to analyse the sample. Cystic fibrosis is an exception, where they do some genomic sequencing as well. And then if there is any abnormal results found, parents will be informed by telephone, and then they'll bring the baby in for some confirmatory testing, and then there'll be a referral to any relevant specialists or multidisciplinary team clinics. But genomic newborn screening is, which means basically the introduction of genomic sequencing technologies into newborn screening programs is, we think, inevitable. Basically, it is already happening in many places in a research setting, including England, in the UK, some in Europe as well. And as I'll explain to you in a moment, we've been doing some here in Australia too. So really the questions we need to be asking is not if we should be doing it, but really focusing on when and how we should be implementing genomics into newborn screening programs in an ethically appropriate manner. So there are some benefits of doing genomic newborn screening over standard newborn screening practices. Basically, we can test more conditions a lot more quickly, which then increases the chance of getting a diagnosis for babies in a much shorter period of time. So we reduce that diagnostic odyssey that babies will often have in order to try and find a diagnosis, particularly with quite rare conditions. It also reduces invasive investigations. So sometimes kids have to have things like muscle biopsies and things. We don't need to do that anymore. And then you can implement treatments and preventative measures a lot more quickly, which it really improves the health outcomes of these babies. But there are some challenges associated with introducing genomics into newborn screening. And some of those questions that we have to ask about are what to test for, because obviously there are lots of things we could test for, but where do we set the boundary about what's appropriate to test for in that newborn period? And we need to think about who makes those decisions about what to test for at that time as well. We need to think about how to properly and adequately inform prospective parents about the newborn screening process when you include genomics, and especially when there's so many more conditions that are going to be tested, to make sure that they are able to make an informed decision and therefore give appropriately informed consent for that test. We also need to think about what kinds of results we're going to be reporting back. So with a biochemical test, it's usually very clear whether it's a positive or a negative test. But when we're doing genomic sequencing, there are different classes of mutations or variants that we could report. And so we need to think about whether we're just reporting the things that are class 4 and class 5 variants, which means that they're pathogenic or likely pathogenic, so very likely to be causative of the condition, or whether we also report things that might be a little bit more iffy, so variants of uncertain significance. And what happens if we find things that we weren't expecting, so incidental findings? Do we report those as well? Then we need to think about the impact on the healthcare system of finding all these babies a lot earlier in their healthcare trajectory and what that means for their follow-up care. And then we need to think about who's going to pay for this, because genomic sequencing is a much more expensive test than the standard newborn screening test. But we need to think about should parents be paying for this themselves, when that it would potentially increase health disparities in the population. So there was a Genomic Health Future Fund grant that was, there was a call out a few years ago where 5 groups around Australia were given $3 million over 3 years. And we were lucky to get that as part of the Baby Screen Plus program is what we developed. And this is led by Associate Professor Sebastian Lunk and also Professor Zonetta Stark at the Victorian Clinical Genetics Service. So this is the program that they've implemented, which is Genomic Newborn Screening for Personalised Lifelong Care in Australian babies. And it's really a feasibility study. So we're trying to figure out if we can actually do this potentially at scale. So in the interim, we've been screening 1,000 babies for just over 500 conditions and trying to look at a lot of different aspects to do with health economics, bioethics, science implementation science, etc., etc. So today I'm going to talk about the ethics stream of what we've been doing, which is trying to figure out what the public think about implementing genomics into newborn screening programs. And so the aim of this study was to explore the public's perspectives on a bunch of different things, but looking at benefits and concerns and also implementation. So things about how we should offer it, when we should offer it, what conditions we should test for, all those sorts of questions I was mainly mentioning before as issues. So I had the help of my colleague, Dr. Fiona Lynch, to perform some focus groups. The focus groups, we recruited participants via Facebook advertising, which was actually really great. We got quite a lot of people interested, and we screened for eligibility and diversity to try and ensure as broad a group as possible from the population. We did get a little bit of skewing in terms of the people who participated. There were quite a few more people who were on maternity leave than we expected, which is probably not surprising, and also a few more people who had a child with a genetic condition. So we need to take that into account, but in some ways they are also the more relevant people to be making decisions about this. So before we got them into the focus group, I got them to watch a video that I had created, just telling them a little bit about what newborn screening is and genomics was, and basically just postulating that we should combine the two, but not really giving them much more information about that because we wanted to leave them quite open for the discussion. So we ran focus groups that ran an hour and a half. We also conducted a Mentimeter, which meant that they got to rank the different characteristics that came out of the discussions as things that were most important to them. And then we recorded that, transcribed it, and analysed it using inductive content analysis. And that link there is just in case you haven't gotten sick of my voice by the end of this conversation and you want to hear the video. So just on the participant characteristics, we had 75 participants participate over 15 focus groups. And you can see there the mean age was about 42, but we had a really nice age range between 23 and 72 years. So it covered quite a large range of the population. We managed to get representation from both metro and regional and rural areas. We had people who did and did not have children, but obviously more who did have children. It was really great that we got some people who had who spoke a language other than English at home and also who were born outside of Australia. And we got some males as well, which is always hard to do in qualitative research studies. So the results I'm going to present today are 5 different components of the questions that we asked. And I'm going to just talk you through those. So firstly, we wanted to explore the overall perspectives on genomic newborn screening. And we actually asked a couple of poll questions to begin with. And the first one was, do you think genomics should be used in newborn screening programs? And you can see here, so we polled them both before and after the discussion. So pre-discussion, you can see here that 34 out of we actually only, we only did this on half of the sample because we just did some focus groups to begin with and asked this question. So out of the 39 that participated in this question, 34 said that they thought, yes, we should be using genomics in newborn screening programs, and 5 said they weren't sure. And then post-discussion, you can see there that more people said they weren't sure about this, and some people said no. So just hold on to that answer for a second. And then I'm going to say the second question, which was, should a newborn screening program that includes genomics be run any differently from standard newborn screening programs? And you can see here at the start of the discussion, 18 said yes, it should be run differently, and 12 were not sure, and 8 said no. And then after the discussion, you can see there that quite a lot more said that it should be run differently from standard newborn screening programs. And we didn't explore that in that question, but later on through the conversation, it came out that this was usually to do with the consent process. And I think this is a really important finding across these two questions, is that when we talk to people about this, it seemed that they actually understood the complexities of newborn screening, including genomics, a lot more than they had prior. So that's really positive in terms of how we can potentially educate people to make informed choices about this technology. So then, in terms of the qualitative research, I'm going to present some quotes as representations of the conversations we had. So participants were generally in favour of genomic newborn screening, and this was generally because there was this potential for more children to receive early treatments and surveillance. So as this participant said, if there's any information that as a parent could be helpful, particularly if there are a lot of early interventions for a multitude of conditions that are really, really beneficial, and the sooner that you might be able to access those, the better, really. We talked a bit about when to deliver the information to parents about the potential for testing, and the participants generally thought that parents should be informed during the pregnancy. So this participant said, I kind of wonder whether that first appointment where women have just found out they're pregnant or they're planning to become pregnant, I wonder whether that would be a good point where you don't have any brochures yet. You've got that time to sit down with your partner or read about it and decide what you want to do, so that down the track, when you're completely overwhelmed, you at least have a good base understanding of what the testing might involve and whether you want to take part in it or not. And this participant said, waiting until the baby is born is too late. I think it needs to be during pregnancy, and also perhaps education packages for people who are trying to become pregnant as well, so they've got more of a chance to learn about it. There was just definitely a sort of a preference for the information to be delivered in person, and then also to accompany that with written or online materials. This person said, I think you probably want a health professional delivering the information, and then some people won't want to know anything further. They'll understand it. Some people will need a fact sheet. Some people want to watch a video. I think you need a human at some point too. And this person said, maybe there's an online video you can watch or whatever that explains what it's all about. And then you can decide whether or not to consent to it at that point for when the heel test is being done. We talked about who would be the best people to deliver this information, and the participants felt that midwives, general practitioners, and obstetricians would all be equipped to have these kinds of conversations. This person said, either their GP or the midwife, just in their general checkups, if they're the people that you're regularly going to talk to about pregnancy, then it would make sense that they would let you know the option is available. So having someone who you already had a rapport built with was quite critical in that. But then some participants felt we should also allow access to a genetic counsellor if needed for extra information. So this person said, I was just going to say, we've talked about who delivers the information, perhaps if that information is going to be delivered by non-genetic counsellors, where there's like a national genetic counsellor hotline that you can call if you had further questions and you didn't understand something. You can speak to an expert, and it's not based on where you are for your care. It's available to everyone. We talked quite a lot about consent, and they were quite clear that a consent should be opt-in specifically and not just opt-out. It shouldn't be mandatory, but it should be revocable. So people should be able to change their minds, particularly if consent was obtained before the birth, and then we would want to reaffirm that at the birth when the sample was being taken. So this person said, I think it needs consent for it. Some people may not want to know, I guess. And this person said, I think there's also needs to be an opt-in or out. Like if you want to change your mind over the process, you can. Like I know people go in with birth plans and think they wanted it this way, but then realize halfway through it can be different or something. I don't know. But yeah, I think maybe do an early consent and then reconfirm at collection, because they may change their mind to say they would decide they would want to do it when they said they didn't want to do it or something. We talked a bit about this idea about consent being different depending on compared to standard newborn screening, as I sort of highlighted earlier. And some people felt it should just be the same. So this person said, I don't think the consent process should be any different, because at the time you're providing consent or not, you would have gone through all the information about genomic testing and what it involves. So if you do have any questions, absolutely feel free to ask. But I think the consent process in itself shouldn't really be different from the newborn screening test as it currently is. But other people felt it should be different. And one of the things that they differed on was whether both parents would need to give consent to the testing. So this person said, so I think we're talking about a process of screening. So these are children that don't exhibit disease. If they were a child that is exhibiting a disease, I think I don't actually have a trouble with having genetic testing at that point without having consent from another parent. Should not be available because the child has a condition that is exhibited and we're using the genetic information to help treat the child. I think my main concern is that if it's a screening process, it's something it might not necessarily exhibit. So I do believe that both parents should be consented. And probably unsurprisingly, there were quite a few parents in our study who didn't remember giving consent for standard newborn screening. We hear that a lot. So this person said, I distinctly remember being asked if I wanted 12-week screening, but I don't distinctly remember being asked about the newborn screening test. And I don't know if my husband did that and I didn't, I'm not sure. So this was really just highlights the fact that it's such a crazy time and there's lots of things going on and people don't necessarily remember what they were consenting to. So I'm just going to move on to condition selection now. And there was quite a lot of discussion about which conditions to include and how we make those decisions. So some people said that they felt all conditions should be included. So this person said, I would just want as many conditions as possible to be tested, treatable or not treatable, severe or not severe. Anything that can be included that's possible, I would really hope for. I would just hope that as much as possible could be included. But others presumed we need to make some priority decisions about what to include. And we didn't actually prompt that. That was something that they decided themselves. And it was often based on the thought of whether it would cost too much to include everything else rather than it being an ethical decision. In terms of who should make those decisions, our participants really wanted either health professionals or people with lived experience to make those decisions rather than them themselves, which is interesting because we were including them in the study because we wanted them to actually help us with these kind of questions. So this person said, I don't have any lived experience directly of any conditions. And I think the opinions of people who live maybe with these conditions might be, I think their opinions may in some way be more valuable than mine. So maybe getting more opinions than just like the people who have had more of a lived experience of this would be really, really helpful, I think. I want to defer more to them. We talked about what to include in terms of the conditions, and some people felt that only treatable conditions should be included. And this was really based on the potential for psychological negative impact on the parents or even the child. So this person said, we know that we can screen for many different diseases, but we don't have treatments and cures for many diseases. So you're potentially sort of coming up with a genetic diagnosis at a young age for a young child, with the parents then being faced with not having any treatment for that child or for treatment outcomes. I think it would be my main hesitation, I think, with offering it at the newborn level. But others felt that it was actually important to include untreatable conditions because having that information, they could still access support and plan for the future, and that actually may maybe treatments in the future that we don't know about yet. So this person said, I think it's important not to just identify cases where there is a treatment, because I do still think it's significant for families regardless of treatment. If you do have a child that has a terminal diagnosis, it's still important that odyssey to find out what it is. We talked then a bit about including adult onset conditions in newborn screening, and some people felt that that it was appropriate to. So this person said, I think even if it's something that's going to affect someone later in life, it should be detected early in childhood, because it could be a family history there that could be detected through this, and it could make life a bit easier for the adults if it is detected. But others felt that it wasn't appropriate to include adult onset conditions. And this person said, I think that that's something that adults should be allowed to decide for themselves. I don't think it's up to the parents to decide it's in their right to obtain that information. That's not something that I would want my parents to decide for myself at an early age. Regardless of whether people felt that adult onset should be included or not included, there was a definite sense that childhood onset conditions should be prioritised. Then we talked a bit about severity, and some people felt that it was only appropriate to include severe conditions. So this person said it should be based on the seriousness of the condition that's being tested for. And this person said, and for me, I would want to know the most important ones would be the more debilitating conditions, anything that's going to affect my child's mortality and anything that's going to affect their ability to, again, have a normalish life. Whereas others felt that All conditions should be included regardless of severity. So this person said, just because something is considered mild doesn't mean it may or may not need support in the future. And so I think that whether they're mild or more severe cases of each thing, it would still be important to be able to get support for these kinds of things. I suppose just in the future for that child, because mild things in anything really doesn't mean you don't need help or support with that. And then finally, we talked a bit about cost and how to fund this. And so there was a general sense that this should be publicly funded as per normal standard newborn screening programs. This person said, I don't think you could ethically offer something like this and not make it accessible to all, or just make it accessible for those who could afford it. It would be a non-starter. I would rather not have that system at all if it's only going to be available to people who had middle-class income or higher. And there was kind of this discussion that it would actually save the government funding in the long term if we do this earlier. So especially not just the intervention and further costs down the track, but also the diagnosis. That can be very costly because there's a range of specialists and people involved to determine what the issue could be. So if that was determined from birth, it would be a great cost benefit. They talked about whether there's a few different models about how this could work in terms of funding. So some people said it could be partially funded, subsidized. This person said, I wonder as well if there's any option, like if you are financially disadvantaged, could Medicare cover this for you? And then if you have the money to pay for it, so you just have to pay for it yourself if you want. And then some people also suggested tiered testing as an option. So this person said, obviously it would be nice if it was all covered by Medicare, but in our realistic world, it sounds like it's going to be super duper expensive. So yeah, I think a compromise to that would be, okay, here are we're going to test for these top 50 conditions. And then if you want to test for this and this, it's optional, but it's an extra charge and people can decide for themselves. And then some people felt that we should be offering genomic newborn screening even if people have to pay, so not just saying, well, we can't afford to do it publicly, so let's not do it at all. So this person said if it could be available earlier on to some people, like do you withhold it from some people who can pay just because others can't? I think that would be, there's a whole lot of moral dilemmas there. And then it was important to acknowledge that we would need to have funding to support the families after the diagnosis. So having the information is all very well, but you need the services available to actually offer the therapy and so on. So there's a lot I've just covered there. I'm going to hand over to Chris, but I just want to do, there's one more quote. Potentially there's going to be more families that get a diagnosis early on in a fairly tricky or fairly challenging time of parenting, and just ensuring that there's the workforce to support that, I think would be really important. So I just want to acknowledge that other people who are part of this and all the participants. And I'm going to leave it to Chris to help discuss some of this in his presentation. So thank you. Stop sharing so Chris can take over.
Great, thanks, Danya. So I definitely can't discuss all of the issues that you've raised, but I discuss a few of them. So we'll see how we're going. So yeah, thanks again, Danya. Thanks, Megan, for hosting and the introduction. I'm going to talk about some of work that I have sort of done in this space and some of the sort of general ethical sort of debates that are arising about genomic newborn screening. And then at the end, I'll discuss some of the sort of planned work that I'm planning to do in the next sort of year or so. So work that I'm, really keen to sort of delve a bit more into some of these questions. So although, as Danya said, there's now a lot of interest in genomic newborn screening and there's lots of projects underway around the world, it's important to note too that there is also a bit of skepticism about genomic newborn screening, and there's some sort of criticisms in the literature, and there's sort of a debate now about sort of clinicians who are very pro going in these directions and some more skeptical voices saying that we should really wait a bit more for this. So some of the ethical questions that get raised in the literature are things about it like informed consent. So given this really complex test, how are we going to help ensure people make informed choices and choices that support their autonomy? And this is particularly complicated when we're talking about newborn screening and we're trying to get consent from people who've just given birth to a baby, because we know it's not a great time to sort of get information and be able to reflect on it. There's concerns about data privacy. So when you do genomic newborn screening, you generate lots of data that can potentially be used in lots of other areas. I'll talk a bit more about that in a few slides. But there's this concern about, well, what do we do with this data that's generated and how can we ensure that people's privacy is protected? The potential for genomic newborn screening to result in inaccurate results is also a prime concern. So it could generate false positives, or so where people think that you think that a baby's sick and they're not, or false negatives, which is the opposite. And a lot of this stems from the fact that a lot of what we know about genomics now and genomic associations with disease has been done in studies on populations of sick people. So that, we know that so many people have a disease and we genotype them and we think, oh, here's an association between this variant and disease. But when we're talking about screening a healthy population, these relationships can get more complex. And there's lots of studies that we've shown that once we thought we had a variant that was causing a disease, when you look at thousands of people, actually a fair few people have these variants and are healthy. So it's not causal there. So these are things that we really need to sort of sort out and could be sort of negative consequences if we don't consider them. As Danya said, so some types of genomic results are what we call variants of uncertain significance, where there's uncertainty with decision making. So this might be where you find a mutation in a gene that you know is implicated in a disease, but you haven't quite seen this precise variation yet. So you're not sure. Clinicians won't be sure if that is causing a disease or not, and this can create stress and uncertainty. And then there's these broader system questions about, well, if we do this, is it going to be cost effective, particularly if we're creating lots of uncertainty? How do we know that this will actually be beneficial for the health system and won't just sort of overwhelm clinicians' time with these other sort of other follow-up tests and things? And relatedly, maybe by looking at genomic screening, we're overlooking perhaps more effective screening tests that are simpler than genomics. So all of these are really important practical questions, but I want to sort of reflect on how are these really ethically distinctive questions, and actually are they actually ethically challenging things to think about? And I'll note that so when we do any screening test, and including newborn screening, there's a fair few guidelines about how you should run these programs and what are the costs and benefits and how you should sort of implement them. I've got a picture there of the book from Wilson and Younger, which was done in the 60s. So this is a very famous list of screening criteria that you often see listed in talks and things about newborn screening. I don't quote them here because I don't think they're very well worded. But my point is that when you read the book that they've done, they consider all these things that I just talked about. So they consider overdiagnosis, overtreatment. They consider what to do with uncertain results. All of these things are kind of already known that they arise in other screening tests. And the difference with genomics is more different in degree and kind. So although I don't like the Wilson and Younger guidelines that much, their wording, I've got quotes here from the UK National Screening Committee's guidelines on population screening. The quotes I have, I think these were done around the year 2000. They're still active, but my main point is that these were written before genomic newborn screening. They were just criteria for any sort of screening program. They say things like the benefit gained by individuals from the screening program should outweigh any harms, for example, from overdiagnosis, overtreatment, false positives, false reassurance, uncertain findings and complications. And likely the opportunity cost from the program should be economically balanced in relation to expenditure and medical care as a whole. So although genomic newborn screening will raise these questions, and it will be practically challenging to determine what is the cost of overdiagnosis and what is the cost of the health system. The ethical calculus is more or less the same that it is for these other screening tests. We need to understand this data, and then if there are cases where overdiagnosis and these externalities outweigh the benefits, we shouldn't implement it. But when the benefits outweigh these externalities, then we should implement it. So I think the general point is that when I sort of read critiques of well, genomic newborn screening will lead to lots of overdiagnosis, it will flood the healthcare system with uncertain findings, they seem to be assuming that genomic newborn screening will be implemented in ways that disregard these current guidelines, because these current guidelines clearly say that if we have evidence of these concerns, we should not implement it. So I think these considerations, support our current approach to genomic newborn screening. As Danya said, this has now just been done in a research context around the world. No one's doing this as a sort of clinical care first round trial. It's all being done, the intentions of gathering data. Things like overdiagnosis and uncertain results are going to be really context dependent. They're going to depend on which population you're screening, and they're going to depend on what diseases, what genes that you're looking at. So it's really important to get good data from lots of different populations so we can make these informed decisions about when genomic newborn screening is actually offering a benefit that outweighs the potential cost that it might weigh. So this is my sort of blurb to say that this PIT, I don't think, is that ethically distinctive from other screening. As I said, it's more practically challenging because these things arise and we need to have lots of data, but ethically it's the same sort of consideration. But there is an aspect of genomic newborn screening which I think is ethically distinctive and does raise interesting ethical questions. And that's the fact that when you do genomic newborn screening, there's sort of two components. You're generating data, you're generating the genomic sequence, the raw data, and then you're using data in these particular ways to look for these childhood onset diseases or other sort of things. But the fact that there's these two questions can kind of change the ethical calculus, because even if we think generating data, even if we think using data for newborn screening doesn't deliver that much benefits, perhaps the lifetime benefits of getting this data and storing it for the lifetime and doing it will actually be a beneficial overall. So I did this paper, Danya's on this paper as well, and it was sort of, the concept was led by John Christodoulou, who's at the Murdoch Children's Research Institute. And it's this sort of model of screening called sequential interrogation, where basically you generate data at birth, and then you use it at different time points through life, depending on what the cost-benefit ratio is. So again, perhaps when at the newborn stage, you generate the data and you might use it just as a second tier to newborn screening. So that means we do newborn screening as usual, but you can use the genomic data to help improve the accuracy of those results. And it can give you sort of greater clarity on your traditional screening sort of questions. Then you don't need to do anything, but if a child gets sick early in life, then you interrogate the data for reasons that is causing an illness. So Danya and I have also been on this project about genomic sequencing for critically ill children, and there's really strong evidence there that the availability of genomic data has real clinical benefits. And it's also clear that the faster that you have this data, the better the clinical outcomes are for really sick children. So this is another way that this can sort of provide a benefit in this space when you look at it this way. Further on in life, you might do another round of screening when someone's in their sort of adolescence. You might think, well, now we do screening for adult onset conditions such as predisposition to cancer, to heart disease. There's a few studies right now at Monash which are sort of looking at the utility of doing this in adults. If a person does get an adult onset condition like cancer or heart disease, you could do pharmacogenomic testing with the genomic data, which means you can look at the genomic data and predict how they might respond to various treatments and sort of tailor the treatments to their sort of genetic sequence. That one. If people are starting a family, you could use the data for sort of reproductive carrier screening, which is then when you can predict the chances of children having a disease, which is we've done through Mackenzie's mission. And perhaps somewhat depressingly, genomic data is also useful after you die because it can help do, if you've got the sequence data there, it can help do a sort of molecular autopsy. So yeah, as I said, I think this does it changes an ethical calculus somewhat. We have to think about not just, is there reasons to generate data and use it just for newborn screenings, but is there reasons to generate data and then have this data as a lifetime sort of health resource? So I think it raises really sort of interesting sort of questions. One of the benefits about such a model where you generate genomic data near birth is that in general, birth's a really good time to get data from people. So because everyone sort of comes into contact with the health system generally at birth, the screening programs with the best population coverage are ones that tend to happen near the birth. So I've got a picture there of a baby getting a hearing screening test. So we know those screening tests are have the highest participation rate because you're getting babies through the sort of hospital at birth, and their participation rate is over 97%. So it could be a really good time to generate this data for future benefits. And not only, I think, is this good because you get more clinical benefit from the data. If you get it at birth, you can use it at those early sort of time points. But it's also potentially, if you're going to use this data for research purposes, a really good way to do it because you're more likely to get representative data from your population rather than just data from the sort of more wealthy people or better off people who then come into the health system sort of later on. So in the paper that we looked at some of these questions and also some of the economic questions. So another model you might think in the future, if we're really serious about genomic data, is not store data, but just sequence and dump it. So either every time you want to, all those different life points I showed in that last slide, maybe we shouldn't be using stored data. Maybe we should be sequencing them each individual time that they need, that genetic information would be useful for their healthcare. That might work if genomic sequencing is much, much cheaper than the storing, but I would still have concerns that it's harder to get to people, all that time. So one of the biggest things about genomic medicine now is the closer you live to hospitals, the more likely you are to be engaged in genomic medicine, just because of the way that the health system is structured. So there is, I think, benefits to this model where you're like looking at it at birth. So I'm going definitely beyond my expertise here, but I think there's like, if you look at human rights law, which I did for another project, what I was really struck by some of these human rights legislation that, the Australian government signed up to, all sort of major governments were signed up to, is just the wording about the sort of maximization of health. So the right that we endorse to health and the health of children is to the highest attainable standard of physical and mental health. So it's not just to a good standard, it's to the highest attainable standard. Not only do we have the right to the highest attainable standard of physical health, but there's the right to enjoy the benefits of scientific progress and its applications. And the rights of the child have a right to the maximum extent possible, ensure the survival and development of children. And because the right to health is a human right, people should be able to enjoy this right without discrimination due to things like your ancestry and origin. So we know with genomic medicine now, this is not happening. So we know that genomics has utility for diagnosis, in screening, and in treatment. But we know that if you're Caucasian from well off, you enjoy those benefits much more than people who have underrepresented genomic data. So I think my point just here is, as if you take this seriously, if you think, well, we really, going forward in the next generation, we want to make sure everyone's got the highest health possible for children and that there's no distinctions in the health between different ancestries, then you need to do something quite drastic. And I would think doing something quite drastic where you are sequencing people at birth, as I said, it's more representative that way, would help build this sort of good database that you can then use for these purposes. So I just want to now talk about two sort of projects that I'm just sort of starting that sort of touch on issues that I've sort of discussed and the ethical issues of newborn screening. So the first is a project on genomic privacy. So this is a Lineage Consortium targeted research project. You can see the people I'm doing it with up there. And the real motivation for this project is to sort of unpack this concept of what genomic privacy specifically is and what its significance is. So although we hear privacy a lot when we hear about genomic data governance frameworks, it's always seen as an important issue. Exactly what it is and exactly when you lose it is sort of uncertain. You can kind of distinguish these two kind of positions in the literature. So one is that genomic data is really sensitive personal data. And indeed, if you look at the Privacy Act, genomic data is a subset of personal data, which is called sensitive data. There's different ways to understand what this means, but some of them I think are clearly wrong. So you might think that means that all of our genetic data is highly sensitive, but we kind of know that that can't be true, right? I've got a picture of bananas there. So we know humans share roughly 50% of your DNA with bananas. It's clearly not the case that if I just shared just the DNA that I have in common with bananas, that I've lost any privacy at all. And it's sort of the same with other data. So although we share 50% of data, genomic data with bananas, with other humans, we share over 99% of data with other humans. And again, it's hard to see how that type of data that we share with everyone could be this sort of sensitive personal data. So the question is, well, when does genomic data become sort of sensitive and personal? When do we lose genomic privacy? So this is sort of some of the questions we want to sort of look at in this project. I'm really interested in the question about, so if you do just raw sequence data of someone, have you lost privacy when someone just has your raw sequence data? Or is it when it's been linked to a disease predispositions or a character trait? When exactly is the privacy lost there, and what form does it have? And the plan is too, there's now like a number of sort of technological solutions to genomic privacy, such as using sort of blockchain to mask particular areas of the genome. So the idea is like, if you could do that, which areas of the genome should you be prioritizing and masking to protect privacy? So this will be a fun project. We're just sort of starting it now. And another project I'm looking at, so this is again a lineage MRFF project. And this is looking at the role of trust and genomics data governance. So again, similar to privacy, trust is a word that comes up a lot in governance frameworks. Often it's presented in sort of different ways. Sometimes it's viewed as a prerequisite for research, so you can't do genomics research unless you have trust with the population. Other time it's seen as a target for governance mechanisms. The goal of our governance mechanism should be promoting trust, should be earning trust of people. But it doesn't go into too much detail after that. So what we want to look at is, well, are there different ways to think about trust, different elements of trust? And particularly one thing I'm interested in is like looking at different degrees of trust, because often it's presented as you either have trust or you don't. But it seems that trust, varies in degrees. So how can we sort of measure this variance in trust, and how can sort of governance measures promote trust? So although I'm doing this conceptual area, this will sort of end the talk well, because I should point out that Danya is also doing work in trust and genomics, and she's looking at how members of the public conceptualize trust and what makes them earn trust in these mechanisms. So I'll be working with her to do that sort of work as well. And that's all from me. So thanks for your time.
Thank you so much, Chris. And I'm just going to pop a link in the chat to the Lineage project for people
thanks,
if they're interested. Thank you so much to you both for such really fascinating talks and very rich, rich learnings of your projects in this area. Thank you so much to both Danya and Chris for those fantastic presentations. Thank you so much for joining us today. The recording of the talks will be available on the Helen website in a little while. Thank you so much.
Thanks, Megan.
Thanks for having us.
Thank you.